If two people are sitting in a computer chair facing each other, and the one pushes against the other one, they're sitting next to each other, their feet are both off the ground, one puts their feet on the other person and they push off, what's gonna happen? We don't want more forces to pull forward on these premolars, because if you do, it just increases the likelihood of those teeth tipping forward and dumping into the space. Right? Because the three things that we're really taking into consideration, what do you need to move teeth? Well, you need force, you need space, and you need time. So this patient comes to our practice, and if you've taken courses from me, you may have seen her case before. So when we look at her facial profile, you see that she has quite prominent lips. So from her nose to her lips to her lips are more prominent than her chin. And yet when we look at her teeth, she has quite a bit of crowding. And the concern here is that if we procline these teeth much further, and they're already very, very proclined, it's likely going to lead to lip incompetence. And so this is a question. She has great arch form, and yes, we will be slightly constricting her arch if we take out teeth. But how do we address the fact that she feels like she can barely close her lips right now at this exact moment, and deal with the fact that she is super crowded? We could do a boatload of IPR on her. That might be sufficient, but in reality, this is a case where I do think that the correct course of action might be extracting teeth. Now here's the thing, is that our goal as dentists isn't always to have the exact plan. Our goal is to present multiple options to the patients, and the patients decide what matters to them. And that's exactly what we do here. So we don't tell her you have to get extractions or don't ever get extractions. We present and say, hey, here's your different options. We can go ahead and straighten these teeth as they currently sit. What's gonna happen with those is it is gonna push out more. We will do some smoothing between your teeth to try to help with the imbalances that you have, right? Trying to prevent your teeth from going too far forwards. But you need to be aware that it's likely still gonna cause your teeth, well, it's not likely, it will cause your teeth to push further out, and it may make it harder to close your lips. Your other options is, well, you could do jaw surgery and try to bring both jaws back, but that obviously is not a very airway friendly method of treating either. And so this is the debate. And I used to love how Dr. Richard Litt used to say that orthodontics should be called compromise-odontics. Because what are you willing to compromise on? Are you gonna go ahead and procline your teeth further and end up with lip incompetence? And potential recessions or gingival issues? Are you gonna take out one lower incisor, but that doesn't help the upper proclination? Or are we going to focus on potentially taking out 4 premolar extractions? And so we present to her, look, this could increase your risk of airway problems. But for sure, something needs to be done in terms of your bite, because you're hitting edge to edge on these front teeth. And what's happening is you are starting to wear down and chip those teeth. So we need to do something. It's just a matter of which direction do you want to go. And so the great thing is, again, is that we present, they decide. And so she says, you know what? I think that taking out 4 premolars is the direction that I want to go. And what I've actually done is I never want to be accused of somebody saying, Stephen, you just treat with your own protocols, you change out attachments every single time, you never give it a chance to use Invisalign's attachments. I don't want to be known that way. And so what I did for this case is, even though I was fairly confident that it wasn't going to behave properly, I asked the technicians for them to give me straight up Invisalign's default. So I said, please use the default optimized attachments, show you here, and default staging without applying any of our protocols. So ignore our special instructions, ignore how you would normally treat this case for me, just do it exactly like you would if it was from Invisalign. Now, one of the things you'll notice here is even with that, what we get back, it still actually has lots of trace. They've actually still slowed down some of the velocities, because normally Invisalign's default velocity here would probably be in the 40 aligner range. So there actually has been a decrease in the number of trays. Oh, maybe let me look. That was actually trim implant 2, so maybe I asked for that change. So it actually happened in 55 aligners with Align's default staging. So I actually, even with all of that, even wanting to let it fly, I cheated. And I told them, no, give me more trays. I'm not confident this is actually gonna happen. And so what the plan is showing is it's showing a closure of the extractions in the upper first and lower first premolar spaces. We've got optimized attachments. this optimized is a maximum anchorage for first premolar extraction. Same thing here. Same thing there. This is an optimized retention attachment and an optimized maximum anchorage attachment for first premolar extraction. So if there's any doubt that these are the exact attachments that Align gives as a default, you can see it right here when you hover it, because this is the only circumstance that it will tell you that it's an optimized, moderate, or maximum, which is interesting because they're showing maximum anchorage retraction on one side, and then on this side they're showing moderate. It's the same exact attachment. It's just something to try and push against to keep the teeth upright here as we close the spaces. So what I'm going to do with these cases is I'm letting it fly. I'm not changing things out. I'm using buccal attachments here. No attachments were triggered for the anterior teeth, which seems kind of crazy because the amount of rotation that's going on here is significant. What actually helps us tremendously in some of these Asian patients is the fact that their lingual surfaces here, though, it's almost like we have attachments on them. Because we have this anatomy, there's almost an attachment on the mesial and an attachment on the distal that helps the tray lock in on those teeth and move. So it's actually more consistent than if you had a patient without those marginal ridges that are so significant. But this is our treatment plan. Retraction of the teeth, rotation, and straightening. Now the thing is that I'm quite confident this is actually not going to work the way shown. The reason why is that, well, we're trying to move so many teeth at once. As we push against these teeth, what moves easier, roots or crowns? It's pretty straightforward. It's going to be crowns because the crowns move through air, but the roots move through bone. And so if these roots lag behind in their movements, then we're going to see the crowns move, but the roots won't. And even though it's showing these back molars not moving forward, the thing I want you to remember is the concept of anchorage. If two people are sitting in a computer chair facing each other, and the one pushes against the other one, well, if they're both on wheels, imagine they're in like an elementary school gym, right? Where there's not a lot of friction at play here. So they're sitting next to each other, their feet are both off the ground, one puts their feet on the other person and they push off. What's gonna happen? Well, the one person pushes off and goes backwards, but the other person they pushed against, that person's gonna move too. It's not like you're pushing against a wall. If you're the same weight, you're gonna move the same distance regardless of who pushes who, right? In a frictionless world here, it's gonna be exactly 50-50 if your weight is the exact same. And so that's the concept of anchorage with orthodontics. It's the concept that even though we're showing retraction of these anterior teeth, the posterior teeth will change their position to some degree, especially if we don't have any elastics at play, because elastics change the situation of anchorage. You can kind of think of elastics like two people are pushing against each other, so one's pushing against the other, but for one of them, with the elastics, you've got a rope hooked up around their midsection and someone standing behind them and they're pulling a little bit. And then for the other person, it's the same thing. Someone's got a rope and they're standing beside the other person with the rope and they're kind of holding that rope tied around them too. So as they try to push back, they can't push back as much. They're still going to push back a little bit. And the other person that's getting pushed against, we're physically pulling them in addition to the force that's generated from the person who pushes with their feet. So elastics can change the conversation of anchorage, but that's not going to be the relevant thing here. The elastics don't actually come into effect because what you're going to see is that these teeth are going to all dump forward. And if you actually had hooked up elastics to this lower first molar, it would actually just make things worse. So the reason why I didn't use any elastics is, well, number one, the patient's in class 1 occlusion. We don't need to change the one arch more than the other. We just need to extract the teeth and then close the space evenly between the two segments, the two arches, I guess. But the second conversation is that we don't want more forces to pull forward on these premolars because if you do, it just increases the likelihood of those teeth tipping forward and dumping into the space. So let's go ahead and take a look and see what actually happens. So this patient comes back in. They haven't been in treatment for that long. We can see that, yes, the spaces are starting to be closed, but what's happening here? Uh-oh, what's actually happening, and we don't have a pen at this time point. I don't think we grabbed one later either because we don't really need one here. But you can clearly see what's the angulation of these posterior teeth. Well, if we're to draw it out, let's do that. Premolars going here, molars going here. Right, everything has some distal angulation or mesial angulation in the anteriors. The anteriors aren't as bad. I would actually even say that this canine's probably more like this. So we might not have bad parallelism between this canine tooth and the first premolar tooth, but especially on the first molars, these teeth have dumped forward. And because they have two big roots, this is going to make things really, really challenging to fix. Right? Because the three things that we're really taking into consideration, what do you need to move teeth? Well, you need force, you need space, and you need time. Right? We even adjusted the velocity on this plan that it happens slower than what Invisalign initially was going to give us. But if force is pushing the crown more, there's space, and there's not enough time, well then crowns move through air, roots don't move. So how do we change that biomechanical situation? Well, the force right now, we want it to control by grabbing the entire tooth and moving the tooth with a full wrap of plastic. So in consideration to that, what we're going to do different on our other patient is we are going to do a few adjustments to the plan that are going to make all the difference in this being successful with the tracking. For those, I didn't do an intro, I didn't go through any of that stuff. I think a lot of you know who I am at this point, but for those who don't, we do only Invisalign. That's all we do. We do clear aligner orthodontics. I work a week a month, sometimes a week every 6, and make more doing this than I ever did doing general dentistry. I don't live in the same city that I practice. I actually travel there. I work my 1 week, and then I get to be a stay-at-home dad, and I get to lecture and teach doctors. It's super enjoyable. The lifestyle is amazing. My staff enjoy it more because they get more autonomy and more control. And so this is what I do. This is my passion and my mission. Our goal is to change the way that general dentists do orthodontics, being able to do it to a higher standard with more confidence. If you watch this right now and you said, wow, that's really complicated, I want you to understand the principles more than putting it all together in this case. I want you to just understand that if you have a tooth that needs a lot of movement, don't close the space around it. Move the root first, then move the crown. Right? I want you to understand the principles, but my goal is that I don't want to dumb it down for you. I want you to understand that you can be treating these hard cases and you can do it really well. I'm not here to show a fake reality of everything that always works. That's why I show those cases that sometimes aren't going well. And I try to show you what I would recommend changing and adjusting. But the main thing is that we want to support general dentists like yourself to grow. We have a number of different courses where we do that live and in person. And we have lots of courses and content available online. So check that out. But if you want more than that, that's where our community with Clearly Select comes in. That with our community with Clearly Select, we're here to support doctors in every area, in live time, giving them updates with support with their ClinChecks, giving them support with their business strategies, giving them support with their staffs and their team. We're here to really bring your practice to the next level. The doctors who join our community grow by over 20 cases each year. If you do the math on $5,000 per case over 20 cases, that means that you are growing at $100,000 of billings. And the other thing my goal and vision for you is to charge more for your cases. We charge almost $8,000 for our standard case. And so I want you to be able to have that same profitability because in the end, the only number that matters is the one that you take home. There's over 5,000 dentists that I've taught. I think it's 6,000 at this point. And we have more than 500 practices that we work with intimately, supporting them on their clear aligner journey so that they increase their profitability. Again, the average practice is growing their profitability. It's by about $120,000 per year when they're in Clearly Select. There's huge discounts, collectively putting our purchasing power together so that we can grow the discounts for doctors and leverage more savings for you. We have office hours where we go through your ClinChecks. We have orthodontists on faculty. We have dentists on faculty. Our goal is to change the orthodontic world for GPs. And so if you want to know more about that, please jump on a call with one of us or just keep checking out the free content that we give because if this is what we give for free, what do we give for paid content?